Dr. Realobit, Serrano, and I are going to be providing you solutions for some patients with difficult to treat atopic dermatitis. So atopic dermatitis is actually the most common chronic inflammatory skin disease in adults and children. Strong associations are seen between atopic dermatitis and mental health because patients with these conditions are usually having chronic and troublesome symptoms that can affect their quality of life. It's also very important that it has no permanent cure, such as in asthma and food allergies, such that it becomes a burden to the society. So in this survey done among different general practitioners and specialists, we see here that atopic dermatitis is the most common chronic skin condition in all age groups, second to seborrheic dermatitis. So the prevalence of atopic dermatitis has been rapidly increasing. And we have seen in this slide from the International Study of Allergy and Asthma in Childhood that atopic dermatitis prevalence has risen in the Philippines for around from 5.2% to 7.8%, which is actually reflecting changes that we have in our environment. In a latest study done in 4 key cities in the Philippines in 2016, this was done in children 0 to 12 years old, we see an even higher prevalence of 20%, showing that these indeed are diseases of the 20th century. Now, atopic dermatitis has several clinical features, and we have here the essential features of pruritus, facial and extensor eczema in children, and flexural eczema in adults with a chronic relapsing dermatitis. Now, there are also other frequently associated features, such as a personal and family history of atopic disease, the propensity for cutaneous infections, extremely dry skin, the presence of a positive allergy test in many patients, and some other skin conditions like the presence of pityriasis alba, which is hypopigmentation of the skin. So there is no diagnostic test to diagnose atopic dermatitis. It is really a clinical diagnosis, and we use this criteria called the Hanifin and Reiter criteria to make that diagnosis. The 3 main features must be present, most important of which is pruritus. The second is a chronic and relapsing eczematous lesion, and a typical morphology and distribution of skin lesions like what we see in children and adults. Take note that a family history is no longer an important clinical feature in the Hanifin and Reiter criteria because nowadays, even without genetics, you can actually develop this disease because of environmental influences. So I will be presenting to you 2 different scenarios or presentations of atopic dermatitis. You commonly see this child, a 3-month-old with rashes affecting the cheeks and the neck, and take note that there is perioral sparing. This child, who was formula fed, actually was brought to our clinic for allergy testing because they thought food was a trigger, and they found that the allergy tests to milk were negative. This patient readily responded to topical steroids and emollients and outgrew the disease by the age of 5 years old. However, there's also another child who was 2 years old who had a persistent generalized rash since 3 months of age. This patient had to be hospitalized because of erythroderma and hypoalbuminemia and had failure to thrive. Her total allergy level was very high, and he was positive to different types of allergens, especially food allergens like egg whites, milk, soy, and peanut. Unfortunately for this patient, there was poor response to topical steroids and antihistamines. We are also aware that atopic dermatitis can come in 2 forms, either the acute eczema, okay, which can last for just a period of around 1 to 3 months, or the chronic types of eczema that can present with lichenification. And the importance of talking about these different scenarios is that we have to realize that atopic dermatitis has a variability of clinical phenotype and severity. There's also variability in genetic background and known pathomechanisms. So there is really a difference in pathophysiology of the different types or presentations of atopic dermatitis. So because of these distinct progression patterns, we have to tailor-make sometimes our prevention and management strategies for the patient depending how they present clinically. So I will be giving you a brief background on how atopic dermatitis develops. In other words, its pathophysiology. So the main problem in atopic dermatitis is a dysfunctional skin barrier. Now, the skin is our first interface to the environment, and it is also a multi-tiered barrier with a function to retain moisture and repel allergens and microbes. Now, it is not just a physical barrier. We also have microbes that are on the surface of the skin that provide protection against destruction of the skin cells. We also have chemical barriers that are found within the epidermis, and the immunologic barrier, which are the different immune cells that are found inside the dermal portion. So we have to see that if we have a break in the skin barrier, in any level of the skin barrier, you may have the disease of atopic dermatitis. Now, an important element now that is being discussed and has been further studied because of its possible strong role in the development of atopic dermatitis is the role of filaggrin, which is filament aggregating protein that is a key protein which binds the keratin to epidermis. Now, in atopic dermatitis patients, it has been shown that almost 50% of them may have a genetic mutation to filaggrin, which is the key structural protein that will keep the skin barrier intact. Now, what is the role of filaggrin in the skin barrier? It provides structural integrity and skin strength. It also provides moisture and hydration because filaggrin, when it is broken down, produces natural moisturizing factors. It also provides the normal acidic pH of the skin and is important for regulation of skin proteases. So unfortunately, we do not yet have the prevalence of filaggrin mutations in the Philippine setting, but we know that once there is a mutation in filaggrin gene, the type of atopic dermatitis is more severe, and there is a very strong relationship to asthma. So in the development of atopic dermatitis, it occurs because of a genetic predisposition of a defective skin barrier that will lead to the symptoms of our patient, but with environmental triggers that are either allergens from airborne or contactants or even food and irritants like climate and emotional stress, climate changes, and maybe harsh detergents. This will actually bring about these symptoms of atopic dermatitis. And infections have actually been known also to be triggers of atopic dermatitis. So just like any other allergic disease, atopic dermatitis arises due to gene-environment interactions. And it occurs at certain age wherein the patient becomes vulnerable and the patient can manifest the clinical phenotype of allergy. So this is like what we see in the diseases now of the 21st century, wherein many patients are having genetic predisposition, but when they are exposed to the environment, it will lead to clinical disease. So allergies are really IgE-mediated responses to antigens, and they can manifest as either asthma, allergic rhinitis, atopic dermatitis, and food allergy. And the environment has been known to influence the type of clinical disease the patient has, but genetics will influence the severity of the disease expression or the phenotype. So what do we mean by a phenotype? It is an observable characteristic of an individual that can be influenced by genetic and environmental factors, and there are many various causal pathogenic pathways specific to subgroups of patients. So this slide just tells you that atopic dermatitis can have a gamut of different causes. Okay, some may be more of a genetic phenotype, or those that have a problem with their barrier, with the immune system, or maybe because just of the quality of the skin, or the patient is really more allergic than other people. So atopic dermatitis has a natural history. Before, we would say that you can outgrow an allergy,
But nowadays, we have seen that we no longer outgrow an allergy because of the environmental changes that we are experiencing. So 60% of patients with AD are free of symptoms by adolescence, but 50% can recur in adulthood. And in fact, 40 to 60% of pediatric AD patients continue to have symptoms later in life. We are actually now seeing more and more adult patients developing de novo atopic dermatitis at older age. So what is the risk factor for a more persistent course? If there's an early onset disease, a severe early disease, concomitant asthma and hay fever, because we know that atopic dermatitis is part of what we call the atopic march, which starts with the skin, progresses to the airways, either through asthma, and finally to allergic rhinitis or vice versa. And it also, another risk factor is the presence of family history because of the presence of the atopic. So when we talk about dermatitis, these are diseases that are recalcitrant. There's an increased disease severity, a chronic or relapsing course. The triggers are generally unknown and they are unresponsive to usual medical treatment. Now we have to differentiate, of course, this from the severe forms of atopic dermatitis. When we have severe atopic dermatitis, these are resistant to your usual medications of topical corticosteroids, calcineurin inhibitors, and UV therapy. So it is similar to difficult to treat atopic dermatitis. Okay? Difficult to treat can be recalcitrant or severe. And severe atopic dermatitis occurs with an immediate flare-up after tapering your topical anti-inflammatory disease. It entails a long, continuous condition where specialists considerably affect the quality of life of the patient. So how do you know if a patient has severe atopic dermatitis or not? We actually use a very objective score called the SCORAD index. Complicated, but just suffice to say that if your scoring is severe, you would have a score of 40 to 103 based on these different parameters, like the extent of atopic dermatitis, the intensity, and subjective symptoms. So we compute the objective score to give you an accurate classification of atopic dermatitis. Now, when we talk about severe atopic dermatitis, this really means early onset career, which starts with the atopic march. And when we talk about atopy, we mean that the patient has a genetic propensity to produce IgE in response to environmental stimulation. Now, these severe types of atopic dermatitis are associated with many comorbid conditions and overall poor health. Many of them have food allergies, asthma, uncontrolled allergic rhinitis, periodontal problems, dental problems, skin infections, especially eczema herpeticum. Now, as I mentioned previously, loss of function mutations in filaggrin have been seen in patients with atopic dermatitis. However, we have to note that it doesn't mean if there is a filaggrin mutation or deficiency that it is the only reason why your patient can have atopic dermatitis. Patients with severe atopic dermatitis, we must provide early intervention and disease-modifying strategies before serious pathologic changes, such as an increase in IgE sensitization development or IgE autoreactivity begins. So we must always review the fundamentals of therapy before prescribing the more toxic and systemic immunosuppressive therapy. So these are the first-line treatments for atopic dermatitis. It is a systematic, multi-pronged approach in managing our patients. The first and most important maneuver is to provide adequate skin hydration through emollients. The second is, of course, to give the drugs of choice, which are the topical anti-inflammatory medications. The third is to provide antipruritic therapy. The fourth is to provide antibacterial measures. And the fifth is, of course, to eliminate exacerbating factors that have been objectively determined. So let us look first at the quality of skin of patients with atopic dermatitis. They are called xerotic skin. These are dry, fine, scaly, hyperreactive skin that has a decrease in water binding and an increased transepidermal water loss has been impaired. There's decreased sebum production or lipid production, and thus a decreased protective barrier and an increased risk of infection is seen in these patients. So in the stepladder treatment for atopic dermatitis, even just for cirrhotic skin alone without the active lesions, we must provide always adequate skin hydration, and emollients are the advisors of choice. Aside from emollient administration, we must avoid the antihistaminic triggers, whether it be allergens and irritants that come from the environment. So what do we mean by the first way, of course, and it is very practical, is to bathe. Now we have to emphasize a daily bath, especially here in the Philippines, because sometimes we think that just because the skin is very dry, we do not need to bathe the patient. But bathing is important to take out the debris from the skin and to take out the microorganisms that may overgrow in these patients. The baths must have a lukewarm water temperature. We can sometimes use soaking baths or wet compresses of around 10 minutes or wet wraps if the patient's skin is severely diseased. The uses of cleansing agents have to be chosen well. The use of non-irritating types that are moisturizing, slightly acidic, or with a neutral pH and fragrance-free. We must avoid scrubbing or rubbing the skin that may elicit pruritus in these patients and lead to disease activation. Now, the second means of cutaneous hydration, of course, is to provide a moisturizer. We adhere to the 3-minute rule, which means immediately after bathing, the patient must apply their moisturizer all over the body and not just to affected skin. Especially in hot weather, wherein the moisturizer may be removed because of sweat, we must increase the frequency of application. And again, the choice of fragrance-free and slightly acidic moisturizers that are tailor-made for atopic skin. Now, in trying to control atopic dermatitis, we must also realize that we have to control the triggers. Even though we have intact skin, if the triggers are not addressed, then you will never have control of your symptoms. So we must try to break what we call the itch-scratch cycle, because atopic dermatitis is known as the itch that rashes. Okay, once the patient, even the skin is normal, will feel the itching, he will scratch it, and that is the time the rash will emerge or erupt. So let us talk about pruritus. Okay? Pruritus actually is not only mediated. We have to realize that there are other mediators that may cause pruritus in these patients, and a lot of them are neurogenic in etiology. That's why the role of antihistamines is not really very clear in atopic dermatitis. In some of the summary statements in the latest practice parameter of atopic dermatitis, some patients that have urticaria or allergic rhinitis may benefit from the use of the sedating antihistamines for the relief of pruritus at night. But see, the grade category is only C, meaning the evidence is not really strong because we do not have a lot of randomized controlled trials to prove this type of management. And also, we do not advise the use of topical antihistamines because of potential cutaneous sensitization to the topical antihistamines. So the role of antihistamines is really the patient has a histamine type or histamine-induced pruritus, then that might be helpful for this patient. Now, we have to realize also that there are different trigger factors for the exacerbations of atopic dermatitis. They can range from emotional factors all the way down to food allergens. Now, a most common implications, and we have to say that only 40% of patients who have the severe type of atopic dermatitis has a food trigger. Okay? So if the patient has only a mild type of atopic dermatitis, we do not have to withhold the diet to these patients because this might cause malnutrition in a patient that really would need this type of food. Now, if the patient is allergic to food, we actually document this objectively through what we call the allergy skin test or the serum IgE testing. And if ever they would be positive to allergens, I have listed here the top allergens that are known to cause allergies, like eggs, milk, wheat, soy, peanuts, nuts, fish, and shellfish. So chicken is not here, nor is chocolate. No, that's the commonly misconstrued trigger for food. Sometimes we keep on looking at the food, but we forget that there are other triggers like contactants from very harsh detergents, perfumes, even from their own sweat, aeroallergens like dust mites, molds, and of course the infections. So if you look at the important triggers based on infancy to adulthood, we see here that food is more common in the younger age group, okay? But the infections and the inhalants are actually more common in the older age group. So infections are one of the more common triggers of atopic dermatitis, especially those that are triggered by Staphylococcus aureus. Now, even in normal skin, it has been shown that Staph aureus is present in 90% of AD skin, even though that the skin looks normal. There is a super antigen effect that leads to a chronic sustained immune response, and thus treatment with antimicrobials may be warranted. We must also be wary of the problematic methicillin-resistant Staph aureus that will not respond to a regular topical antimicrobials or oral antibiotics. Now, aside from Staph aureus, certain fungi like Tinea rubrum or Malassezia furfur can actually be a trigger for atopic dermatitis. So, because the next stage in treating atopic dermatitis is the use of topical steroids or topical calcineurin inhibitors. These are actually the anti-inflammatory drugs of choice for a disease that has an underlying inflammation. So if you look at the stepladder treatment, as the disease becomes more intense, we have to step up either from a low to mid-potency topical corticosteroid or TCI to a mild mid to high potency topical corticosteroid. And this diagram actually is a stepladder wherein you can go up, can increase the intensity of your therapy, but at the same time you have to also decrease it or step down or taper once the patient's skin conditions are controlled. So, as I mentioned, topical steroids are the drug of choice for atopic dermatitis management. However, there are certain practices that can lead to incomplete responses. So even though sometimes we use the drug of choice, you do not have a good response and you would label the patient as difficult to treat. Well, one problem is a step-up approach is used far too often, meaning many doctors tend to use a very mild topical corticosteroid if the lesions are already moderate to severe. So we have to do it the opposite way. Try to get a more potent topical steroid, and once it is controlled, you will step down. Second most important feature is the patient does not use subsequent maintenance therapy through a proper skincare regimen or the use of emollients or what we call proactive therapy, wherein we can apply the topical steroids maybe 2 or 3 times a week even on normal looking skin to prevent flare-ups. And one more important barrier to effective use of topical steroids is the steroid phobia. Many patients and even sometimes doctors are fearful of the side effects of corticosteroids that would lead to insufficient topical treatment and thus poor clinical outcomes. So we have to recognize all these practices that can actually hamper our patient's response to our medication. So how then can we use our topical corticosteroids effectively and safely? First is the dose frequency is once or twice a day. Remember that it is still a drug and that we have to use a certain amount using what we call the fingertip unit method. So this method is by using a strip of topical corticosteroid from the first crease of the adult finger until the tip of the finger, and that amount will be applied on a certain portion of the body. So there is actually a scale for this, which is not in our slides now, but should you have any questions, we might be able to provide you with slides or the chart for the using the fingertip unit method. The next is the duration of treatment. Remember, topical steroids are not lotions, so they have to be given only at active pulses for 1 to 2 weeks. We do not advise continuous use of topical steroids because eventually you would develop absorption in the skin and effects on the hypothalamic pituitary axis like you would give oral steroids. So patients are at risk rather for developing Cushing's syndrome. The use also of proactive therapy can be done, corticosteroids or topical calcineurin inhibitors. And don't forget to taper your topical corticosteroid. Maybe after a week of high-dose topical corticosteroid, you must step down to something that is of lower potency. Now, these are the different rankings of the topical corticosteroids. We have here class 1, which are the super potent topical corticosteroids, and the very mild ones. Now, we have to at least know one potent, one mid-strength, and one mild so that we know what to step down to and what to step up to. Proper TCS choice is based on the severity and location of the rash. We must also choose a proper vehicle for the type of topical steroid we will use, and it is often more efficacious to use our topical steroids in well-hydrated skin. So after a bath or a sponge bath, and the patient has pat dry already her skin, then that is a good time to use your topical corticosteroid. Now, also, the type of topical steroid, the type of potency that you will use will depend upon the area wherein the lesions are. So the low potency topical corticosteroids, which are the class 6 and 7 topical corticosteroids, are those that are to be applied in the face, the groin, and axillary areas. The mid-potency steroids can be in other areas, and high-potency topical steroids like betamethasone and clobetasol are hardly used in children and are reserved usually for thick lichenified areas and in the palms and soles. So the vehicle does make a difference. Okay? We choose the ointments if the skin is very dry, thick, or hyperkeratotic because it is more lubricating and occlusive. It is more absorptive, thus it is more potent, and we cannot use it on the hairy areas. The creams, though, are lubricating and more cosmetically appealing, but they can contain preservatives that can be irritating and allergenic later on. So indeed, there are patients who develop allergies even to their topical corticosteroids. They are also advisable for exudative and moist areas and may be used in the hairy and intertriginous areas. The lotions and gels sometimes have alcohol and can be stinging and drying. So these are usually reserved for the hairy areas. So let us recognize some common pitfalls in managing atopic dermatitis and why it becomes difficult to control. First, there's the inability to recognize and control the trigger factors. So we have to try to control the trigger factors so that the patient does not become recalcitrant to treatment. Sometimes there is failure to institute the first-line concomitant barrier restorative measures with the anti-inflammatory agents. So we must use our topical corticosteroids with our emollients or moisturizers for a beneficial effect. The third is inadequate and inappropriate anti-inflammatory treatment. Because of steroid phobia, sometimes we try to avoid the use of anti-inflammatory agents, and that will lead to poor control of disease. Another problem is the development of contact allergies to topical corticosteroids. We have to recognize that patients who do not respond or worsen their lesions with the topical treatments may actually have contact dermatitis to the topical corticosteroids. Another problem that may lead to difficult to control atopic dermatitis. We have to try to fulfill, remember, the Hanifin and Rika criteria. If the patient has a lesion that is non-pruritic, you have to think 10 times if this is atopic dermatitis. Remember, it has other differential diagnosis that we will be discussing, and poor patient compliance because of steroid phobia. Sometimes, if you do not check if the patient uses their topical steroids or their moisturizers, they will tell you, I am not getting better. And you have to try to always encourage your patients to use their maintenance therapy to prevent flare-ups. So here are the differential diagnosis of atopic dermatitis. We have the allergic or irritant contact dermatitis. The difference here is that usually it is found on the area of application, not like in atopic dermatitis, which has predilection sites. Like for the infants, they have it on the cheeks. Okay, for infants, they have it on the extensor surfaces. And for older children, they have it in the flexural areas. So contact dermatitis is only on the area of contact. Another differential is psoriasis. The rashes of psoriasis are different from that of atopic dermatitis, and maybe Dr. Serrano will be discussing this briefly, how to differentiate psoriasis from atopic dermatitis. Which is cutaneous, it's a form of an infection, it's a fungal infection. The scabies, okay, this is often mistaken for atopic dermatitis, and we know that scabies, you have to actually check the family members or caregivers. If they actually also have lesions, then you also might have to think of scabies. Cutaneous T-cell lymphoma is more common in the elderly, but it really looks very clinically like atopic response to the topical corticosteroids. And in patients who have immune deficiency conditions, these are rather rare conditions, but they also do have severe recalcitrant atopic dermatitis. So finally, if your patient does indeed have a severe recalcitrant atopic dermatitis, then this is the time we use the systemic immunosuppressive treatment. So when do we start a systemic treatment? We have to allow age-appropriate physical and psychological growth and prevent complications such as growth retardation and behavioral deficits to improve the quality of life. The presence of subjective symptoms, especially uncontrolled pruritus, secondary restlessness, and sleeplessness. Many patients, of course, will not have severe complications of atopic dermatitis, but the complications on behavior and also on quality of life are extreme, such that it has been said treating a child with atopic dermatitis is like treating a child who has diabetes. Okay? So before initiating systemic therapy, a clinical and laboratory workup of the patient is mandatory. So here is a list of different systemic immunosuppressive and immunomodulatory therapies that can be given to these patients. A lot of them are third line, and a lot of them still need to be studied because the risk benefits of these treatments have not been actually determined. So systemic corticosteroids are oftentimes if the patients do not or respond to the topical or corticosteroid. These should only be restricted to break severe exacerbations of atopic dermatitis. However, even though we know that it has an effect on controlling or removing the rashes, we have to realize that controlled clinical trials are lacking. So how do we use this? At 0.75 to 1 milligram per kilo per day and should be tapered within 7 to 10 days. But oral corticosteroids are not recommended to induce stable remission of AD because it can produce a rebound effect. Okay? So we do not also advise it because of potential side effects on our patients. So finally, I will share with you one particular management strategy that may have a potential in trying to control atopic dermatitis. And this is the use of vitamin D. Now, vitamin D is not just a vitamin for our bones. Okay? It is actually also an immunomodulatory substance. And because of our habits nowadays that we're always indoors, that we do not drink too much milk because we are on a diet, or we are wearing sunscreens because we do not want to get wrinkles, then we actually lack a lot of vitamin D production, and vitamin D deficiency is becoming very common in our clinicals in the Philippines, even though we are a tropical country. So vitamin D has been known to affect both your innate and adaptive immune system, and thus deficiency might contribute to a defective skin barrier and chronic skin inflammation. Vitamin D is important to stimulate antimicrobial peptide expressions by endothelial cells and in T-cell proliferation. It has been found that AD patients with low vitamin D levels profited from vitamin D supplementation for 3 months. However, we cannot outright recommend this treatment because there's still a lot of clinical trials that have to be done showing whether it is beneficial to really give vitamin D supplementation to treat atopic dermatitis. So we just have to guess. So in summary, atopic dermatitis is a chronic skin allergy which presents with various clinical phenotypes depending on genetic and environmental factors. Severe atopic dermatitis presents as a chronic and relapsing condition recalcitrant to regular treatment and affects the quality of life drastically. Severe atopic dermatitis is characterized as an early onset disease with highly atopic features and comorbidities such as asthma and allergic rhinitis. And before using systemic immunosuppressive therapies, please review first the fundamentals of therapy to check for any lapses in treatment protocol before you use these more potent and toxic therapies. Systemic immunosuppression is indicated only when topical therapy has been properly maximized and when the disease and its complications has actually addressed. There is no systematic therapy that may be recommended for treatment with the exception of cyclosporine due to lack of clinical data. And always remember that the benefits of any treatment must always outweigh the risks. And finally, if you have a problem already with your patients with difficult to control atopic dermatitis, your friendly specialists, the dermatologists and allergists are here to help you control this chronic condition. So thank you very much for your attention.
Thank you for that insightful lecture, Dr. Recto. As of 12:30, we have 59 logged in through the GoToWebinar and 30 in live streaming. Again, we would like to thank today's sponsor, Immunorini Philippines, and the Philippine Daily Inquirer, our media partner. Before we proceed to our Q&A portion, let's have our panelists give her reactions. May I introduce Dr. Assunta Cecilia Rialubit Serrano, an Associate Professor of Dermatology at the Davao Medical School Foundation and Section Chief of Dermatology at the Davao Doctors Hospital. May we now call on Dr. Cecile Serrano.
Thank you, Dr. Castor, for the introduction and warm welcome. Let me share some learning points from our esteemed speaker. Presented here a paradigm shift through a regrouping of existing concepts and practices on how one should approach and manage the difficult to treat atopic dermatitis patient. And that paradigm shift is encapsulated in this one important slide that she showed us earlier, where we see the heterogeneity of atopic dermatitis and the percentages of the severity of atopic dermatitis from 70 for mild, 20 for moderate, and 22 for severe. But this is defined according to genetic and immunologic factors. Often in the clinics, a patient presenting with signs and symptoms of atopic dermatitis is initially evaluated if he fulfills the criteria for the diagnosis of atopic dermatitis, usually with the usual criteria that we usually use by Rika and Hanifin. After diagnosing the patient is categorized according to the severity of the disease, often based on the typical clinical manifestations using the SCORAD index. Then the patient is treated according to the stepwise or stepladder algorithm. In Dr. Recto's presentation, she shifted from this usual approach by highlighting two major points. One, atopic dermatitis is redefined of allergy. That environment influences the clinical manifestation, while genetics influences the severity of disease expression. Two, Treatment of atopic dermatitis in all its details is revisited with emphasis on correlating the goals of treatment to the variety in the phenotypic expression of atopic dermatitis, from skin hydration to topical corticosteroid use to addressing environmental triggers. By adopting this approach, the atopic dermatitis patient is managed according to the phenotype concept, where she explained that patients' phenotype reflect pathogenetic pathways specific to the subgroups of patients and thus can have individualized and cost-effective management. So I commend Dr. Recto for emphasizing the understanding of the disease from the immunologic point of view of heterogeneity. And as she summarized in her last slides, we now see atopic dermatitis in a different light when difficult to treat, quote-unquote, or severe atopic dermatitis is defined as a chronic, relapsing, recalcitrant condition that drastically affects quality of life. Atopic dermatitis is characterized as an early onset disease with highly atopic features and concomitant allergic comorbidities, and that reviewing the fundamentals of therapy before considering a systemic treatment is a must. So aside from those points, Recto, I'd like to mention what you mentioned earlier about presence of allergens in topical corticosteroids. Topical corticosteroids are the mainstay of the treatment of atopic dermatitis. However, those steroids also are allergens or may contain allergens themselves. And this is a list of the allergens in the vehicles. Of the 166 topical corticosteroids, 128, including all creams, had at least one of these vehicle ingredients. More generic products were free of allergens than were branded products. Solutions and ointments were the least allergenic vehicles. The most commonly present potential allergens were PPG and sorbitan sequelate. Most prescription topical corticosteroids have the potential to cause allergic contact dermatitis owing to the vehicle ingredients as listed above. Clinicians should be aware of this possibility and should consider prescribing agents that do not contain potentially allergenic vehicle ingredients. Dr. Recto emphasized in the treatment that systemic immunosuppression, immunomodulation, is indicated only when topical therapy has been properly maximized and when the disease causes complications in physical and psychological aspects of well-being. There are medicines now in phase 3 trials, such as these topical and oral medications, crisaborole 2%, apremilast, an oral phosphodiesterase inhibitor, and bimilumab. These are new drugs in the pipeline, still in the phase 3 trials, and as mentioned by Dr. Recto, should be used with caution, well, of course, once FDA approved. She also mentions that there is no systemic therapy that may be recommended for treatment with the exception of cyclosporine due to lack of clinical data. There are new drugs approved for use for other indications that are also used in high-throughput trials and are used by doctors off-label for severe atopic dermatitis, such as drugs for psoriasis. This is ustekinumab and secukinumab. These are monoclonal antibodies that are anti-interleukins, specifically targeting those specific anti-interleukins. We've used ustekinumab and secukinumab for psoriasis, and I had the opportunity to treat a patient with psoriasis with concomitant atopic dermatitis using ustekinumab, and there was he was initially on TNF alpha, which is actually contraindicated for severe atopic dermatitis. When we shifted the patient to ustekinumab, both lesions or clinical conditions improved, Omalizumab is an anti-IgE for bronchial asthma or steroid-dependent bronchial asthma and chronic idiopathic urticaria, and rituximab for lymphoproliferative diseases. All of these drugs are still off-label and may be used only when they've been tested and possibly are being used now by some doctors for severe atopic dermatitis. Well, this drugs or biologics are really being used for psoriasis, and so their use beyond psoriasis should be with caution. So to wrap up future treatments for severe atopic dermatitis, according to Dr. Weaver, control becomes one of the major goals in the management of chronic inflammatory conditions, especially in allergy. And a number of new entities are currently in the pipeline of drug development, and these are the biologicals mentioned earlier. But some of this, we have to note that some of this may have the potential not only to control moderate to severe atopic dermatitis, but also to hamper or hopefully even reverse what was mentioned earlier as the atopic march. So these are promising drugs, and these new approaches may thus reach the goal of disease-modifying strategies, which is one of the goals of the treatment for severe atopic dermatitis. But to end, Dr. Recto reminds us that the benefits of treatment must always outweigh the risks. Thank you.
Thank you for that engaging discussion, Dr. Serrano. So we are now open for the Q&A portion. So you can now send in your questions. So we still do not have questions, so I'd like to give the first question.
You mentioned that most of some patients with atopic dermatitis actually develop contact allergy to the vehicle of the topical corticosteroids. But how often do you get patients who are really allergic to the active ingredient, the steroid itself?
The more common allergenic main ingredient itself is actually betamethasone, and this is not so common. I don't have the figures, but this is not as common as when you get it from the vehicle.
So I've actually seen some patients with contact reactions. There's actually a phenomenon of Dr. Serrano about like a steroid withdrawal of the skin, where patients who are on chronic topical corticosteroids actually have a rebound effect on the skin. So we do not know if it is really a contact reaction or if it is just a side effect because the steroids have been slowly withdrawn. So I guess the best way to identify if there's a contactant is to refer to our dermatologists who do the patch testing to identify which chemical in the topical corticosteroid is the problem.
I agree. We can do, well, you mentioned if the corticosteroid was withdrawn slowly, right? So it would not have been rebound phenomenon.
It was still there, but the patient actually had a flare up, even though it was withdrawn.
So maybe we can call that. It may fall under tachyphylaxis. Tachyphylaxis is when there is a plateauing of the response to the drug, usually beyond 2 weeks. You will notice when we use topical corticosteroids, we use them for 2 weeks and do a therapeutic holiday of at least 2 months, which is hard to do for atopic dermatitis. That's when we try to use the PCIs in between steroids. So maybe that would have been tachyphylaxis, but it is right that it would be good if we can do patch testing. The problem with patch testing is we have to have clearing of the skin lesions before we can do the patch testing. So it really is very difficult to catch the patient without the skin lesions.
Thank you. We have a question here. Based on your experience, what are the foods that are associated with atopic dermatitis?
Okay, I've mentioned this in a previous slide, but remember that food is only a trigger in patients who have the severe, mild to severe type of atopic dermatitis. And it is only seen even in only 40% of these patients. So if ever food is a trigger, then this would be either among the top 8 allergens. The first, of course, is milk, eggs, wheat, soy, peanut, nuts, fish, and shellfish. So these are the top 8 allergens that really are notorious for food allergies and may also be triggers for atopic dermatitis. I'd like to add also that food is not only a cause of exacerbation. Food allergens can also actually food allergies rather, can develop because of the broken skin of our patients. So in very young infants whose skin are abraded and they get in contact with the food from, let's say, a mother who didn't wash their hands while cooking, even though they never ingested the food, the child can eventually develop an allergy to this because the allergen passed through the broken skin. So it doesn't mean that you develop an allergy just because you have eaten it. It can actually be developed through the broken skin of atopic dermatitis.
Thank you. Another question here. Can you comment on the use of occlusion or occlusive therapy for atopic dermatitis?
Okay, start. We usually use occlusion if the lesions are very recalcitrant. And when you use occlusion, you have to be careful because it is like you have increased the absorption of the topical corticosteroid through the skin. So it can be used in highly thick lichenified lesions to try to enhance absorption, but it also cannot be done for a very long time because it can actually cause HPA axis suppression with long-term use. So I don't know if Dr. Serrano has more input about occlusion.
So aside from the indication of lichenified lesions, which is the more common indication for occlusion, and also aside from lichenification, the areas where the skin is thick. In severe weeping eczema, we do wet wraps, but these patients have to be admitted so they can be monitored. The rationale there is to prevent more water loss because of the weeping lesions, and you have to make sure again that, as you mentioned, that there is no superimposed bacterial, fungal infection because you will occlude the infection in the wraps. So these are wet wraps. They're usually wet pajamas that are being used, but in the clinical, hospitals, in patient setting.
So do you put the topical corticosteroid under the wrap?
Usually, we first do it with emollients only, and then for areas where there are lichenified and thickened lesions, then that's where we put in those areas the topical corticosteroids, together with the adjunctive and the wrap. And that also has an added benefit of preventing the patient from scratching the lesions.
Thank you. On a more practical term, there are patients now who would ask their doctors, especially that it's summer, will you allow them to go swimming in a swimming pool?
Well, it's a two-pronged issue. Of course, we want to hydrate the skin, and actually immersing in water, as Dr. Cecil Serrano mentioned earlier, soaking baths can actually be helpful. But if you go to the pool and the patient is very sensitive to chlorine, unfortunately in the country, our chlorine levels are quite high in the pool. So instead of enhancing the skin, it may actually be detrimental. No? So I often advise my patients that they cannot stay very long inside the chlorinated pool, and that if they have to go out after 30 to 1 every 30 minutes to an hour just to rinse off the chlorine, and so that it doesn't irritate the skin further. Okay? But of course, swimming in the beach might actually be okay, but you have to be careful of sunburn because they are also prone to developing flare-ups due to a sunburn.
To add to that, for Absolutely, for severe cases, I would not allow. No. So.
Oh, you were saying about the
about
to
add to Dr. Recto's guide for swimming in the pool or in the beach or salt water. It would be best to not allow patients with severe atopic dermatitis to soak because they might just get superimposed infection. Maybe the mild to moderate, like as she said, before and after they should rinse and put emollients before and after, except that the pool will be lined with emollients.
We have one phone question sent here, so I'll read this. My daughter has been diagnosed with nummular type dermatitis, and she encounters flare-ups almost every month, even if she's well maintained on emollients. She's only 16 months old and I'm hesitant on the long-term use of memetazole. Can you recommend other first-line topicals aside from steroids?
Well, as you've noted in the stepladder approach, in patients who you're scared about giving long-term topical corticosteroids, there is the alternative of the topical calcineurin inhibitors. They do not have the atropogenic potential on the skin and has been studied to be safe if given intermittently for even up to a year. Now, nummular eczema is quite difficult to control, if I'm not mistaken, and a lot of the times it is not related to any allergy. So it is actually a skin barrier problem already. So if you actually look at the 5 steps in trying to control atopic dermatitis, we must try to fulfill hydration, topical anti-inflammatories, and removal of triggers if the patient does have. So maybe that is one of the reasons why this patient has a uncontrolled type is the most common reason is the lack of emollients, okay, and even strong emollients for the very dry skin. For Serrano, do you have any input for nummular eczema?
And maybe oftentimes nummular eczema, well, of course, the first thing would obviously be to make sure that it is the right diagnosis, that it is really nummular eczema. And oftentimes, on top of the nummular eczema, they develop allergic contact dermatitis to the topical medications that are being used, especially like if they do not use the emollients, as you mentioned, they should be baseline using emollients, and maybe do a therapeutic holiday or rest from the use of the topical corticosteroids, and of course not to abuse the moving up to the next potency, but to rest for about 2 months. 2 months. I know 2 months is very long. Probably 2 weeks before you move to the next level or next potency of steroid.
And I think we have to also be aware that the treatment of our patients are important if you try to control their trigger factors, no? Kasi one of the reasons is we sometimes think that it's always the food and it is not the sweat of the patient, which actually I think is one of the #1 triggers now, especially in this season, no? It's the irritant sweat. I have to add this, that we are also concerned in the Allergy Society that there are some tests that are being done to test for food allergies, or they call it food intolerance testing. And these tests actually are not proven for allergy. They are actually only means of detecting serum IgG, which actually just tells you that the patient is tolerating that food. So a lot of patients are put on these very weird diets, and they get depressed because they are deprived of the food because of this test that is being marketed now that has no scientific basis. So we're just warning the public about these tests because they can actually be detrimental to your child's health.
Thank you. We've had quite an interesting discussion on atopic dermatitis. I'm sorry to say that we've run out of time, so once again, I would like to thank Dr. Marysia Recto and Dr. Cecile Serrano for their participation. And for those logged in, thank you also. As a summary, we learned that the prevalence of atopic dermatitis in the Philippines, at least in 4 key cities, is 20% among children 0 to 12 years old. AD is defined as a familial chronic inflammatory skin condition that commonly affects children but also affects adults. And that difficult to treat atopic dermatitis is a chronic and relapsing recalcitrant or severe atopic dermatitis. The diagnosis is based on a constellation of clinical features, and the most common diagnostic criteria is still the Hannifin and Rika criteria, which requires 3 major and 3 or more minor criteria. We saw that atopic dermatitis has variability in clinical phenotype and severity. And for the pathophysiology, AD is primarily a dysfunctional skin barrier defect with mutation in the filaggrin gene for those with severe atopic dermatitis, and this results in immune dysregulation. Several trigger factors were discussed, including airborne and food allergens, contactants, infections, as well as emotional and climatic factors. Now, the management for AD is systematic, multi-pronged approach involving avoidance of triggers, skin hydration, and your different pharmacotherapeutic agents. We also saw the common pitfalls of atopic dermatitis management. So after this session, an email containing a survey link will be sent to you. After answering the survey, your certificates will be sent to you. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials from this session. Thanks for joining us. Hope to see you again in our upcoming webinar on May 2, 12 noon to 1 p.m. Manila time. The webinar is entitled One Airway, One Disease, Allergic Rhinitis, and its Link to Asthma, with speaker Dr. Alvin Sanico. Please invite your colleagues to join this continuing medical education webinar series. All webinar schedules and resources will be posted at www.upn.edu.ph/in behalf of UP Class 1991 and the UP Medical Alumni Society. We also thank our collaborator units, UP Manila Information Management Service, National Telehealth Center, UP College of Medicine Postgraduate Institute of Medicine and Medical Informatics Unit, DOST, ASTI, and Ms. Charisse Orhalo, our host. We would also like again to thank Philippine Daily Inquirer for their support as our media partner. This is Dr. Marian Castor, together with Dr. Marysia Recto and Dr. Cecile Serrano, and the UP Med webinar team closing this session. We hope you have learned a lot from today's webinar. Join us again in May 2. Have a great week ahead.